I've called this next lecture Phoenix Arising from the Ashes, because of the way Levorphanol has been forgotten and is now being remembered and appreciated. I'm very happy to be able to present this lecture on Levorphanol for the treatment of chronic neuropathic and complex pain. We're going to discuss the rediscovery of Levorphanol, its mechanism of action, the advantages and disadvantages when compared with other major opioids, its clinical use and results, and the next steps that should be taken to further strengthen its place in the armamentarium of palliative care. Of the 6 major opioids, Levorphanol is the least known and least used clinically. An excellent opioid marketed since 1958 as Levorphanol, Levorphanol fell into disuse since the 1980s when long-acting forms of morphine, oxycodone, and fentanyl dominated the chronic pain market. It was no longer marketed by 1990. The failure of the conventional opioids to effectively relieve neuropathic pain has stimulated interest in drugs with N-methyl D-aspartate, NMDA receptor blocking activity, methadone and Levorphanol. Marketed since 1958 as a conventional opioid, a mu-opioid agonist, Levorphanol was, along with morphine and methadone, a preferred choice for treating chronic pain in the 1982 edition of Cecil's Textbook of Medicine. It was almost completely forgotten until 2003, when a landmark trial published by Michael Robotham and colleagues from San Francisco compared low-dose and high-dose Levorphanol and showed that the dose-related efficacy of that drug in relieving chronic neuropathic pain. That article by Robotham and colleagues was selected as one of the 5 most important articles of 2003 by Daniel Fishberg in his annual review of the palliative care literature at the 2004 convention of the American Academy of Hospice and Palliative Medicine. That's where I first learned about it. There was, in September and July of 2000, a 2-part series by Daniel Brookhoff in Hospital Practice, which examined the role of NMDA receptors in the spinal cord in producing and perpetuating chronic pain as a disease rather than a symptom. In that article, Levorphanol and methadone were described as having NMDA receptor blocking activity in the spinal cord, in addition to being mu-opioid agonists. An editorial by Kathleen Foley regarding the article by Robotham and colleagues supported their conclusion that Levorphanol could relieve neuropathic pain. My article in the Journal of Palliative Medicine in 2007, Can Levorphanol be used like methadone for intractable refractory pain? And in 2009, a letter to the editor on chronic pain, Levorphanol, methadone, and the NMDA receptor. And then in 2014, in the journal Palliative Care, Eric Praumer's Levorphanol Revisiting an Underutilized Analgesic. In 2015, in Pain Medicine, Dr. Jeffrey Fuden and colleagues published an article, Is Levorphanol a Better Option Than Methadone? And they compared methadone and Levorphanol clinical pharmacology. Their conclusion, Levorphanol is suggested as a better alternative to methadone. No QTC prolongation risk, no CYP450 interactions, more potent NMDA antagonism, low need for adjuvants, no stigma, and better risk-benefit ratio. So let's talk about the NMDA receptor and its relationship to chronic pain. In acute pain, the pathway for acute pain perception is conventional. We all know it. It hasn't changed. The duration of pain is short, and endorphins and enkephalins are released by the central nervous system to block pain perception. They come down like a wet blanket and snuff out pain. That's the body's way of relieving pain. And opioids, the conventional opioids, effectively relieve acute pain by acting primarily on mu receptor sites in the dorsal horn of the spinal cord. Now, when acute pain changes to chronic pain, this is the setup. Acute pain causes the release of the neurotransmitter glutamate. Glutamate binds to AMPA receptors, amino 3-hydroxy 5-methyl-isoxazole 4-propionic acid. We call it AMPA, AMPA. These receptors in the cell of the dorsal horn triggered pain signals to the central nervous system. When AMPA receptors are saturated by glutamate after repeated activation by chronic pain, changes that activate NMDA receptors occur in the spinal cord. The activation of NMDA receptors marks the transition to chronic pain. And in the graphic on the left, you see a rather simplistic routine with acute pain as contrasted to the number of reactions that we will talk about in the production of chronic pain. And these are, first, wind up. This means that there is more intense, harder to relieve pain. It gives you more bang for the buck. Neural remodeling, there are changes in the nervous system that result in hard to localize pain. Third, the activation of neurokinin 1 receptors, which release substance P, a potent inflammatory peptide affecting both the central nervous system and the peripheral tissues. Fourth, afferent becomes efferent. Nerve conduction, normally going in one direction, can, in certain circumstances, go in both directions, which makes the possibility of a pain receptor cycle. And then finally, neurogenic inflammation involving synovial and connective tissue damage from chemicals released by substance P. I think this is the most important slide you will see. If you can understand why conventional opioids don't relieve neuropathic pain and NMDA receptor blockers can, my job is really done. Damage to sensory nerves can cause neuropathic pain syndromes and render patients insensitive to pain suppression by the conventional opioids. After tissue injury occurs, A fibers, large myelinated nerves that transmit touch and sprout new terminal branches, synapse with pain-sensing cells in the outer, I stress, outer dorsal horn, which lacks opioid receptors, thus rendering endogenous and exogenous opioids ineffective. However, NMDA receptors are there. Types of neuropathic pain that are difficult to relieve include phantom limb, chronic regional pain syndrome, diabetic neuropathy, shingles, and other neuropathic pain syndromes. So let's talk about the NMDA receptor blockers for treating chronic pain. Of the opioids, there are two, methadone and levorphanol. Of non-opioids, dextromethorphan, ketamine, amantadine, memantine, and there's a question about Haldol. It's too early to know about that one. Dextromethorphan has not proved effective in chronic pain treatment. Ketamine is. And so we have, the others are not really clinically important. So we really have methadone, levorphanol, and the non-opioid ketamine who are useful clinically in blocking the NMDA receptor. So ketamine is an anesthetic administered by subanesthetic intravenous or subcutaneous infusions for intractable neuropathic pain, almost always in the hospital. Outpatient setting, ketamine can also be administered orally, intramuscularly, as a transdermal cream, or as a nasal spray. Evidence-based studies are underway to delineate best practices for this potentially important drug in managing pain at end-of-life and end-of-life depression in cancer and other illnesses. Now, methadone, a synthetic opioid developed in the 1940s, has been used worldwide for pain relief. In 2000, it was the 10th most widely used worldwide in hospice care. In the 1980s, the development of sustained action morphine, oxycodone, and fentanyl relegated methadone to use primarily as a treatment for substance abuse until recently. Methadone, like levorphanol, is both a mu receptor agonist, like morphine, and is a blocker of NMDA. We think that methadone and levorphanol are currently the best choices to manage chronic neuropathic and complex or mixed pain. So when would someone consider changing to levorphanol and methadone? Well, when pain control provided by other major opioids is ineffective or causes adverse effects, especially when the patient's suffering is severe, or when adjuvants, the anticonvulsants, the tricyclics, and others are being used to treat neuropathic pain and complex pain are ineffective. When cost is a factor, methadone is preferred. Now we're going to talk about levorphanol and my clinical experiences with it. Now, the advantages of levorphanol. It is a mu, kappa, and delta opioid agonist. It is as potent as the conventional opioids. It is an NMDA receptor blocker, which relieves neuropathic pain. It has a long half-life, dosed every 6 or 8 hours orally. There is no stigma and no unusual adverse side effects. It has no QTC effect, and it has no CYP 450 activity. Its disadvantages, its cost. Very recently, new promotion and marketing, poorly conceived, cost is problematically high. There's no parenteral form currently available. Little evidence-based documentation in the literature of its efficacy in the treatment of neuropathic or chronic complex pain. Its safety profile needs more data, and its dosing interval is shorter than of the long-acting fentanyl, morphine, or oxycodone. Levorphanol can be administered orally or parenterally, either subcutaneously or intravenously. It is poorly absorbed when given sublingually. There are no data on the effects of spinal dosing. Initial doses in the opioid-naive patient parenterally 0.5 to 1 milligram every 6 to 8 hours, or orally 1 to 2 milligram every 6 to 8 hours. Total daily doses should not exceed 3 to 8 milligrams parenterally or 6 to 12 milligrams orally in opioid-naive patients. The conversion ratio of oral to parenteral levorphanol is 2 to 1. The ratio of oral morphine to parenteral morphine is 3 to 1. in converting treatments with other opioids to treatment with Levorphanol. It is recommended, based on our experience, to use tables in the appendix for converting the other opioids to and from Levorphanol. My personal clinical experience with Levorphanol from 2001 to 2008. Patients with complex chronic neuropathic pain or mixed nociceptive neuropathic pain treated with Levorphanol in an outpatient palliative care setting or in hospice, the number was 73. 70% received excellent, score 0 to 3, or fair, score 4 to 6, relief of pain. In comparison of 2,409 hospice patients, those treated with methadone for chronic pain, that number was 375 patients. 75% received excellent relief or fair relief. Now some case reports employing Levorphanol. Case 1, ulnar neuropathy. This 46-year-old male attorney had suffered ulnar nerve injury that affected the left hand and forearm during a 4-hour complicated coronary bypass operation. Lancinating burning pain, best pain level 5, worst pain level 9 on a 10-point pain scale. There were weak interosseous muscle function. After 12 weeks, constant pain and poor relief with hydrocodone and gabapentin. An infected leg vein wound was treated with rifampin, and he had a past history of type 1 diabetes with only fair control. And he was referred for palliative care consultation 3 months after the surgery. We offered him Levorphanol, the 2 milligram tablet, a half tablet, 1 milligram every 6 hours for 2 days. Pain was slightly less. Increasing to 2 milligrams on the first dose, the lancinating pain subsided to a level 0 to 1 on the pain scale and did not recur. Mild burning pain was present with Levorphanol, 2 milligrams every 8 hours. It did respond to Levorphanol 3 milligrams every 8 hours, and then several months later he underwent surgery for nerve entrapment. He has maintained excellent pain relief on Levorphanol 4 milligrams every 12 hours for over 1 year. Next case, a cancer of the tongue. 56-year-old man with cancer of the tongue underwent radical resection of the soft palate and hemiglossectomy. Recurrence of this aggressive tumor to the oropharynx, sinus, and cheek caused severe chronic trigeminal and glossopharyngeal neuropathic pain. He had a long history of anxiety and panic attacks. He was admitted to hospice and with a pain level at 7 to 8, methadone oral concentrate via PEG tube, and he was receiving 5 milligrams every 8 to 12 hours through the PEG tube, but he wouldn't take it regularly because of his anxiety about methadone. Levorphanol, 2 milligrams every 6 hours, relieved his pain to a level 5 on treatment day 5. It was increased stepwise to 12 milligrams in 24 hours to control pain at a level 5 to 6, then increased to 16 milligrams in 24 hours for a number of days, and the pain level was at level 3 until he began to deteriorate, and his death occurred about 4 months later. He had a treatment of terminal delirium, which required chlorpromazine, but he had no apparent pain during his last week of life. Now, case 3, diabetic neuropathy in a 78-year-old woman with type 1 diabetes, heart disease, and osteoarthritis. She was irritable and depressed with a pain level of 8 or 9 on a 10-point pain scale. Gabapentin, conventional opioids, were ineffective in relieving her pain. She reported impaired ability to perform the activities of daily living. Methadone, 2.5 to 5 milligrams, reduced her pain level to 4 to 5, but it had to be discontinued after 14 days because it induced drowsiness. Levorphanol was begun at 2 to 3 milligrams every 6 hours, plus oxycodone, 5 milligrams twice daily for breakthrough pain. Her pain level was 4 to 5, and it was then bearable at level 3 to 4 for the next 6 months. Cardiac and brain function then worsened. The patient was admitted to hospice, home care, and Levorphanol, 2 milligrams every 6 hours, reduced her pain level to 3. Patient's condition progressively declined, and she died comfortably about 3 or 4 months after being in hospice. So, what are the next steps with Levorphanol? Evidence-based studies, controlled studies, for instance, Levorphanol treatment for chronic neuropathic pain, Levorphanol as first-line treatment for cancer pain, Levorphanol as treatment for severe non-malignant chronic pain, and head-to-head comparative studies with other major opioids, and basic research. Certainly consider the National Institutes of Health for grant support. In summary, the standard of care for the treatment of chronic pain is changing as we learn more about the ways in which chronic pain develops and is perpetuated. The role of NMDA receptor activation in this process appears very important. As an NMDA receptor blocking opioid, Levorphanol has great potential as a first-line agent for treating chronic pain, especially neuropathic pain. Thank you. The appendix which follows contains a number of important additional information on the topic of Levorphanol.